So again, welcome. I think we're going to have an exciting, although somewhat quick, tour through a variety of different aspects of new information for acute kidney injury biomarkers. And I'm going to start with talking about this concept that Claudio introduced briefly, which is this concept of renal stress and biomarkers of renal stress that we can hopefully apply at the bedside. My disclosures are here. I'll also be talking about some emerging data concerning the use of biomarkers in conjunction with remote ischemic preconditioning. This is the revised clinical conceptual model for acute kidney injury as of about 2011. This is a model which I think has undergone continuous evolution and revision over the last several years, and in fact, it gets presented fairly regularly at this meeting and other international meetings, and I think each year there's some improvement in our understanding. But we recognize that there's this period between the clinical manifestations of acute kidney injury, which we can see as a change in function or an increase in damage markers, that we call risk, at least in this model. I think we can conceive of this risk both in terms of static variables, like the types of conditions that one has, such as underlying disease, heart disease, diabetes, chronic kidney disease, susceptibilities for acute kidney injury, as well as exposures that patients have, sepsis, radiocontrast, nephrotoxic medications. But in addition to that, there's this concept that's emerging that we're beginning to understand as the reaction of the kidney to those stressors. This also illustrates that the change in renal function and the increase in kidney damage are two separate sides of the coin and don't necessarily have to be in complete syncopation with each other. We also understand that this is both a model for evolving kidney dysfunction as well as resolution. This is that concept of damage versus function, and there can be a situation where there is damage without loss of function, which you could only identify via biomarkers or imaging or tissue. And there's a situation in which there is a functional loss without evidence of damage that we'd talk about as purely functional change. But even a purely functional change, which is profound and persistent, can put the organism at risk for death and various other complications. And then, of course, damage and loss of function together is the classic manifestation of acute kidney injury. And certain biomarkers have different profiles in terms of the time response to insult. You can see here, for example, that NGAL is increasing before there's a change in function as measured either by cystatin C or serum creatinine. You can also see, however, in patients that don't develop AKI, there's an increase in the biomarker signature above the normal range, even though it may not get into the range that's associated with acute kidney injury. And then in various studies, there's more or less overlap between the no AKI group and the AKI group. We might think of this as a false positive when the AKI biomarker rises and there's no acute kidney injury. But if we're defining acute kidney injury purely on the basis of late functional changes, we also have to recognize that there's a subclinical AKI that biomarkers may be detecting that serum creatinine or urine output or any other test that we can make of function does not test. But it's more than that, because the timing may not be in that order. You may have function declining after damage begins to occur, as is shown here, but you may have function changing as damage is evolving, as shown here, or you may have function beginning to decline prior to the advent of damage. If you were to put a snare on the renal artery and stop renal blood flow, there would be an immediate decrease in function, but damage would only begin to occur after some time. And there's also this concept of stress that I alluded to. What is this renal stress? This is the kidney's response to a sublethal or subinjurious injury, a subinjurious stimuli, which can also be an important clue that something in the kidney is going on that could be a trigger for therapy. And of course, there's molecular basis for this. The kidney is in the position of filtering from the blood a variety of molecular patterns, both damage-associated molecular patterns, pathogen-associated molecular patterns, cytokines, various drugs, which stimulate pattern recognition receptors in the proximal tubule that then results in a cascade of events which ultimately can lead to loss of function or progressive injury in the renal tubules. This signaling occurs in both a autocrine, self-stimulating, and paracrine, near-stimulating, such that endothelial cells communicate with each other to warn each other that there is, in fact, a stress. This stress can be injurious or it can be pre-injurious, but nevertheless causes signaling to occur. This is then linked to loss of function by downregulation of cellular metabolism, decrease of transport of solute, decrease of sodium and chloride uptake, and ultimately through tubular feedback, a decrease in GFR. When we look at the markers that appear, the biomarkers that appear in the kidney and their relationship to these molecular events, we see that two markers that we hadn't previously recognized for acute kidney injury, tissue inhibitor of metalloproteases 2 and insulin-like growth factor binding protein 7, appear to be superior markers for detection of these events than the other markers that had been identified previously. The overlap in function between these two markers is in their control of cell cycle response. And there's a list of stimuli that stimulate the release of both of these markers. There's a lot of overlap, but individual markers do have some differences. But they're all responding to threats which can be less than injurious, this concept of cell stress. It's like the psychiatrist for the kidney. The kidney is feeling something, and if it continues to feel that stress, it may result in injury, but prior to injury, it's responding in a way that we can try to detect. Now, the evidence for this is both in vivo and in vitro. This is some data that's been published in abstract form that's currently under review from our group. And this is showing with human kidney cells taken from deceased donors or HK2 cells. And you can see where proximal tubule cells or markers that cells that are exhibiting markers of proximal tubule or distal tubule exhibit both of these biomarkers in response to sublethal injury. In fact, a stimuli that just cause the kidney some stress without causing any cellular damage at least produce an increase in IGF-BP7. We haven't been able to prove that yet for TIMP2, but it seems likely. And we can see this at the cellular, the organ level as well. This is tissue staining for IGF-BP7 and co-staining with markers of proximal tubule, CD13. Further evidence that you can stimulate this response with a subinjurious stimuli come from evidence from remote ischemic preconditioning. This is work from Alex Zarbach and a study we did where we looked at biomarkers in response to remote ischemic preconditioning. Stimuli of a remote source, a muscle, where you put a blood pressure cuff on, blow it up to 200 millimeters of mercury, and you release damage-associated molecular patterns like HMGB1, maybe some myoglobin, uric acid into the bloodstream. The kidney sniffs that. It senses it. The kidney knows that there's something going on in the body that's abnormal and reacts to that by release of these biomarkers, where injury biomarkers like urine NGAL don't change at all until there's an actual injurious stimuli to the kidney. So this is what the model looks like. You've got remote ischemic preconditioning releasing these damage-associated molecular patterns. They're detected by pattern recognition receptors in the proximal tubule cells that release TIMP2 and IGF-BP7 that then tell adjacent cells to downregulate their metabolism to protect themselves from subsequent injury, and AKI is averted, whereas in the sham condition, the naive kidney has no warning that this problem is about to occur. Now, with increased stress, there will eventually be strain and there will eventually be damage. So as the stress increases, the risk of acute kidney injury increases. And you can see there's almost a linear increase in both acute kidney injury by KDIGO criteria or major adverse kidney events, which is the death, dialysis, or persistent renal dysfunction at 30 days. And that begins at about 0.3 units. Now, another aspect is that if this is stress and there's more stress that can cause harm, you would hypothesize that frail kidneys, like in chronic kidney disease, would be more susceptible to the same stimuli given the same measure of stress. And in point of fact, you see here that in a publication just recently accepted a couple of weeks ago, that TIMP2 and IGF-BP7 are even better for detecting AKI in patients that have frail kidneys and patients that have chronic kidney disease with a receiver-operator characteristic curve of 0.9. Why is that? It's because the frail kidney, the CKD kidney, has no capacity to tolerate the stress. It has no renal reserve. So every injury to that kidney, every stressor to that kidney that's picked up by the biomarker is much more likely to result in kidney damage. And you can see long-term effects as well. This is high levels of TIMP2, IGF-BP7 associated with a much higher rate of death or dialysis at 9 months. But coming back to something I said earlier about the stress and the warning, the alarm that this represents, is it possible that you could stimulate an alarm, stimulate stress in the kidney in a good way, tell the kidney to protect itself ahead of the damage? And that's what we did with remote ischemic preconditioning, and it's what we may be able to do with other therapies that I'll talk about on Thursday at this conference. But at the bedside, we can recognize that there's a big difference between no stress, or levels of stress which are less than normal even, and the rate of risk of acute kidney injury is less than 3%, a big increase when it's above 0.2, and when it gets above 2, the relative risk goes up by 17-fold. And there's a list of things that we may well do in response to these therapies, in response to this warning, knowing that the stress is high and doing things that might alleviate the stress, like stopping the nephrotoxic drug, improving renal perfusion, et cetera, et cetera. So in conclusion, markers of cell cycle arrest appear to be robust measures of risk for acute kidney injury, manifesting in the next 12 to 24 hours. They've now been validated in 2,000 patients. The test is FDA approved. The underlying biology suggests an alarm phase marker before actual damage has occurred, i.e. markers of renal stress. Measures to relieve stress may prevent AKI, and the potential to exploit this mechanism as a therapy, such as with remote ischemic preconditioning and potentially medications, to protect the kidney from subsequent injury. And with that, I thank you for your attention.